BioBalance Healthcast episode 140, Women and Heart Disease.
BioBalance Healthcast features conversations about positive aging. Your hosts are Dr. Kathy Maupin, Medical Director of BioBalance Health and a leading expert in treating symptoms of aging, and Brett Newcomb, a licensed professional counselor.
Welcome back to BioBalance Health Podcast. We recently had a podcast where we talked a lot about gender differences in medicine, and we promised that we would come back and talk about specific gender differences in terms of what we are now learning and know about women and heart disease. Kathy has been going on and on about information that she possesses about women and heart disease and how mainstream medicine through the years has not separated out the genders enough to learn these things about women, and she's been on a crusade. And so now other doctors and other medical research are really beginning to get on the bandwagon, and we're beginning to learn some things about women and heart treatments that we have not known, or that has not been the norm. And so we thought we'd spend some time today talking about those to sort of spread the word and give you a platform to explain what you know about the differences between men and women in heart disease.
There's many differences. I mean, there's so many differences. One of them is that we have different diseases that bother us than men. Men don't generally have as many arrhythmia problems as women, or fatal arrhythmia problems.
Okay, so you're going to have to define terminology here. Okay. An arrhythmia is?
An arrhythmia is a heartbeat that is not...
It's not rhythmic. It's
not
arrhythmic.
Rhythmic. It's...
Yeah.
Or... Stop. So basically your heart is not functioning normally. Normally the atria, which are two smaller muscular rooms, if you want to say, in the heart that squeeze, and then they squeeze into the ventricles, and the ventricles are larger, and then the ventricles squeeze, and your blood goes to your lungs, and then the rest of the blood that's on the left side of the heart goes to your body. So when the ventricles squeeze together, so it's bump, 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 bump. It's very rhythmic. It has to be. If it's arrhythmic and they're going, nothing's going anywhere. It's just contracting in different ways, and there's a little blood that goes to your lungs and a little blood that goes to your body, which means that no oxygen's getting anywhere.
So it's a closed pumping system.
Right.
And if it works the way that it's supposed to work, then the blood is pumped around through the body, goes to the lungs, picks up the oxygen, goes to the rest of the body, and distributes that to the tissues. But if the rhythm is off, then the whole circulation process is off.
Right. And so you feel like you're out of breath,
weak, dizzy, exhausted.
You feel you can pass out, you can die, because if the heart starts, this is very simplistic for all you cardiologists out there. So
they're going, oh my God, don't tell them.
Please don't judge me on this. It's so complicated that there's an electrical system that stimulates the atrium and then it goes down to the ventricles, and then that gets stimulated. So if there's a short circuit and you don't get the electrical current from the atria to the ventricle, that's one way to have an arrhythmia.
Right.
Another way is if you have an extra beat somewhere. Sometimes,
just a random extra beat. Sometimes
didn't you ever wonder why you had a heartbeat? Because there's this wonderful SA node, and it has a beat your whole life. It works all the time, day and night, and it gives you the electrical current.
Well, and so when you do cardio exercise, you pick up that beat.
Yeah, the beat responds to your need for oxygen. So that's a normal thing.
All right.
So if you have that SA node, and God forbid you have another little piece of tissue that also has its own beat somewhere else, then you're not beating atrium, ventricle, you're doing atrium, ventricle, ventricle. And so it's just not pumping properly.
Right.
It messes up the rhythm. And the rhythm means it messes up the pump.
But that can be random. That can be like a random electrical spike. And you can have an arrhythmia that just lasts for a few minutes and then go days and days and days without an arrhythmia, and then have one?
Yes, but the arrhythmias that we're talking about are the ones that are recurrent.
Okay.
They happen all the time,
Okay.
or the ones that just don't go away, and that we have to shock the heart to
Or
reboot
sometimes
it.
stop it and then start it again.
Yeah, that's done too. That's a little bit. That's more
serious.
More serious.
Right.
And then sometimes we can find we aren't always able to find. There's a very specific kind of cardiologist that can find this other beat, and then they can use a catheter to find that beat and laser it out.
Oh, wow.
It's very cool, but it takes 12 years of school to do all this.
Yeah.
So they're very specific, specialized cardiologists that do that. They're cardiac physiologists. So they can then get that beat. But there's all kinds of rhythm problems, and most of them happen to women. Not all, but women are much more susceptible to that.
Arrhythmias than men.
And so that's something that we give lots of attention to arrhythmias, but we have not really said, when you look at a woman, consider arrhythmias, because they're more common. It's just, is there arrhythmia or not, and how do we deal with it? Now, one other thing is women have often have a weakness in their mitral valve, and that's the valve between the left atrium, the little room, and the big room. So it's on the left side of the heart, which is going to pump to the rest of the body, and that valve is sometimes flops backwards. It should just open like a door. And if you've ever had like a shower door that goes backwards, it goes backwards a little bit. When it's trying to push forward, it fills a little bit backwards, and that's a mitral valve prolapse.
Okay.
So that's more common in women, and that makes the left ventricle less able to push the blood out well, because a little bit of that energy is going backwards. Does that make sense? So it can't push forward. So we get a little weaker, and it also stresses the heart. So the heart's trying harder.
Yeah.
And so that's a difficulty. So these are two of the more common female problems with the heart, where men have the more common problem of atherosclerosis, where they collect fat on the vessels, and then they have compromise to the blood supply to the heart. If you ever wondered what a heart attack was, a heart attack is where the blood's supposed to be going to your heart through these vessels, and you've probably seen the pictures of them. There's big arteries that go to the different parts of the heart, and then you'll see little if you've ever had a cath, you'll see compromise here and blockage here, and they draw it.
I saw a film one time years ago, Michael DeBakey, famous heart surgeon, doing a heart surgery, and he had taken an artery loose from the heart and taken a pair of forceps, and he was pulling a tube of gunk out of this artery.
Yeah.
And there was just little blood flow coming out, and he said, well, I don't have it all. And he's digging around there. He said, you'll know when I have it all. And then all of a sudden, blood just starts shooting all the way across the room. He said, now I've got it.
Right.
And he just opened it up and took all that blockage out.
It's like putting a dam in the arteries that feed the one muscle you need. You know, so
which is that whole cholesterol thing.
That's cholesterol plus inflammation causes atherosclerosis, or the dam in your coronary arteries.
And that men are more susceptible to that.
And men are more susceptible to that than women. That used to be true. We're coming right up on them, because we now eat as much meat. We now smoke, and oftentimes women don't take estrogen for menopause, and estrogen actually helps decrease inflammation and actually decreases collection of atherosclerosis. So since we've stopped replacing estrogen as much, we've increased our risk of heart disease.
Well, actually, this document that we got out of Gender Medicine magazine said that heart disease is the leading cause of death for women in the United States.
It is.
And it is greater than the next 16 causes of death among women combined.
Right, and that includes breast cancer. So you should be much more concerned about your heart and keeping track
than breast cancer. Although that's certainly a very serious and lethal risk.
But
so is heart disease.
Heart disease is worse. And it's only been recently that we've looked at men and women differently, and it's not complete. I don't believe that we've given the differences between men and women and their hearts enough credit. Some of the other things are men and women respond to the medications we use for high blood pressure and the medications we use for arrhythmias, beta blockers, differently. And we don't separate them in the PDR. We talked about this before. The PDR is the book that gives us all, like it's this thick, and it gives us all the drugs.
PDR is a physician's desk reference.
And that
so
means
the doctor will run to that and look up drugs and complications and indications, and I mean it's where they keep all the data. Now it's all computerized, but
now it's on
it used
my
to be
phone.
this huge, massive.
Now I look at Hippocrates and I put in a drug, and and it tells me all the different doses. And it does not divide between men and women, and there are differences in that. Part of that is that we haven't done the research yet on a lot of them, but we know by practice that if we give a woman this drug, it won't work, and if we give a man this drug, it will, or the same drug. So we divide it up in our heads, but it's not proven. It's not proven by science, and we need to do those studies. But we haven't been doing those studies on women because the FDA didn't want to hurt unborn babies, but they also didn't make a provision for people who weren't fertile. They should. You should not do this on fertile women or pregnant women, but you should do these studies on women.
Women in general.
In general.
Yeah.
And so.
Which they did not do.
They did
the
not
FDA
do.
forbade that in scientific research for years and years and years, and I don't think it changed until the early 80s.
And we get a lot of our research from Europe because they were still doing research on women. And carefully, but they were still doing the research on many of these things, and I think that's what stimulated some of the push, plus this journal, to look at women differently than men and how they respond to the medicines that we use for heart disease.
When she says this journal, she's talking about the Journal of Gender Medicine, which, as we explained in the previous podcast, was a journal that was started by a group of women doctors at Harvard who wanted funds to have a journal to talk about research in women, and Harvard declined to provide those funds. And so they sent out donation requests to all the female physicians in the United States saying, there's a whole lot of stuff about women that's specific to women that is not being researched, that needs to be researched, and we need our own journal. Will you help us fund a journal? And
so we all donated $300.
Yeah, and
we
funded
got a
this journal, which lasted for 10 years. And really opened the eyes of the medical community and the research community to the importance of this. And then other mainstream journals began to do more reporting about gender-specific research.
And there's a huge conference every year. It's in Europe usually, gender-specific medicine. So, and they have a lot of new research there that may not be in the U.S.
Hasn't filtered through yet.
Hasn't filtered through or hasn't been accepted. So it's still proceeding. We're still getting more and more information. But in terms of heart disease, women still do need to look at their cholesterol, do need to look at the inflammation. But it's interesting, in cholesterol, women have a lot higher HDL in general. HDL is protective. So I have to say this because so many people come to me and say, my doctor wants to put me on a cholesterol lowering medication. And women have a lot of complications with that. We tend to have more of the muscle aches and have problems taking medications called statins. So it's important to look at it. It's not just a nothing drug that you can take and lower your cholesterol. So basically, women usually have a higher total cholesterol because they have a lot of HDL. Well, that's the good one. So it's the good cholesterol making your total number high.
Yeah, the LDL is the one.
The LDL is the bad one. And so, yeah, the LDL could be a little bit elevated, but if you've got an HDL that's elevated, it protects you.
Okay.
So when you look down, you have to look at the ratio. There's a ratio of HDL to total cholesterol, and they have a couple other, when they put it into this formula, there's a couple other pieces of the formula that adjust it. But you can tell if you're at risk for heart disease. If it's not above 5, then you're not at risk of heart disease unless you have diabetes to go along with it. I mean, that makes you more susceptible. So yes, it would probably be, even if you're not at a high risk with your cholesterol in the numbers, if you're close and you have diabetes, then statins would be acceptable to try. But so many women are put on them and feel terrible on them, and they didn't really need them to begin with if their HDL was high. Now, most of my patients are on estrogen and testosterone, and both of those help
so women,
the cholesterol.
Women were put on them because doctors were responding to the concern in the way that they had been trained.
Right.
But the training was based on the norm being the masculine norm.
Right.
And so now the research is beginning to say there is a difference for women, and you have to allow for that difference.
Right. So when they look at high and low, there should be a woman's high and a men's high, but basically they assume that doctors know this. So that doctors look down here and go, oh, your ratio's fine, so you don't need treatment.
Right.
But doctors aren't looking at it like that. They're still treating us like we're men.
Right. So they don't necessarily evaluate whether or not you need a statin. They just give you one.
They just give you one.
Based on
what they do with all the men that have
a gender
high
reading
cholesterol.
of the other, yeah.
Right. So they're not making the difference. There's so many different lab tests that should have a male and female difference. And one of them is testosterone. We know that. We've done that. But they also look at thyroid. Thyroid has a male and female normal, and we've known that for 16 years, but it is not on the lab test.
So you talk about Hippocrates or the PDR. Are they now beginning to include dosage distinctions of these different drugs for men and women?
No.
Okay, so they're still rating them mostly as dosages for men.
Right, they're all dosages
So an average
for men.
male
would
be what?
An average male would be 180 pounds,
yeah.
5'9".
Okay.
So
if you're
an average
180
female,
pound, 5'9" woman, you're still not a male.
Right.
And your system is going to be different.
But the surface area of men is getting higher and higher and higher. We grow taller, we are fatter, and so the doses for men.
Yeah, I'm tall around.
Yeah, right. Yeah, you can think that. We're going to have to talk to you about anorexia. But usually the weight of a man is much higher than a woman, and the doses are the same.
Yeah.
And they should be adjusted. In many cases, not all drugs need to be adjusted.
Well, what about women in hypertension? Are they more or less hypertensive than men? Is that a concern?
In general, men are more hypertensive than women, and they have stiffer arteries earlier than women do. Women, because of the estrogen that they've been exposed to throughout their life, keep the elasticity of the vessels. Now, part of hypertension, you have to understand that, is that your vessels get stiff. They don't dilate when you need them to dilate and then contract when you need them to contract. They just stay the same in all circumstances. So they don't respond to what we call vasoactive chemicals in your body that tell your vessels to open up, dilate. So men get much more stiff vessels earlier than women do. So you have to be older to have that same issue. The only catch is if you have a family history of hypertension and you have the genetics for it, then you could easily have hypertension early on, and that has to do with your family history or which actually means genetics. So there are some women that get hypertension early. Most of the time it's men.
And is that, going back to the previous podcast, is that more among black women than white women?
Okay, so then we're talking about there's differences in races and races, and we also talked about the fact that races have mixed so much that it's hard to say this anymore, but this is what we were taught in medical school, that black patients, both men and women, have higher levels of hypertension. And that's one of the things that we're told to look for. The minute we see somebody who is black, we have to think, oh, hypertension, kidney disease, problems with that, that's a genetic difference based on race. I have to say that races are melding. And so that's not necessarily...
So it's not as much of a unique distinction as it was thought to be or was at one time.
Right. And what we're going to have to do is we're going to have to say, oh, not race, but genetic. Everything's going to have a gene for it. In fact, when I read endocrine journals now, they all have the genetic basis for each endocrine disaster that they're talking about.
Well, and you talk about evolution of science and industry around these things. We did a podcast a few weeks ago about a company that you're working with that allows people to get genetic testing to tell them specifically, these are things genetically for which you might be at risk.
That's
and
right.
these are things that you're not genetically at risk for, but you might be lifestyle at risk for.
Right.
You know, in making those distinctions.
Yeah, both things matter.
And
Is your lifestyle and your genetics. It's not just your genetics.
And there are other companies. I mean, there's a lot of, at least, you know, we live and work in St. Louis, Missouri. There are companies that are advertising now and mailers that my wife got some in the mail from another company last week that does the same thing. So genetic testing is beginning to be more affordable and more widely available as medicine is beginning to say, we need new markers, we need new qualifiers by which to learn these assessment protocols.
It used to be so simple. Race, everybody was judged as a male. I mean, but it didn't necessarily mean
visual
our outcomes were good.
Yeah, exactly.
Yeah, we'd look at people and it depended if you were thin. If you were very thin, then we thought of you in one way. If you were normal weight, that would be in that first sentence
Ectomorph,
on
mesomorph, endomorph, male, female, white, black. It was all simple, broad categories.
Yeah, it was. And now we realize there is no one size fits all.
Yeah.
Now, there are some generalities. We're trying to make a generality, male and female.
Right.
But we may skip across this. We may skip across the gender issue totally and go directly to genetics.
And what's unique for you.
Yeah, and you have your own pattern of what is your genetic makeup and your risk. We won't ask your family history anymore. It doesn't matter. We'll have your genetics.
Yeah.
So that's maybe that we skip past a lot of these things. In our genetic tests that we did, I have an arrhythmia and I have a risk for an arrhythmia. So that my genetics played that part.
So that's knowledge that you need to have.
Right, but my family history has tons of diabetes, but I don't have that gene.
Right.
Now, I think anybody can get diabetes if they gain 150 pounds.
Well, that's the lifestyle risk.
Yeah, and eat, bonbons all day. I mean, not bonbons, but sugar stuff.
Right.
And there are some families that's the lifestyle. You have to break from your own training.
Yeah, you need to learn about the glycemic index.
Yeah.
So, I mean, there's just all
He's
kinds
looking
of stuff.
depressed about that because he had to learn about the glycemic index.
Yeah.
So I guess the one thing to remember is that we're all very individual, and medicine is becoming much more individual. We are less like the race that we are labeled as.
Right.
We still have differences in gender, and we always will.
Right.
But we're going to be looked at either as more by gender or more by individual genetics. And that's important for us to know because that may make medicine much more specific and much easier to diagnose and treat somebody. If you have their genetics in front of you and you know, well, you have diabetes, but you don't have a gene for it, so you're doing something wrong in your lifestyle. We have to fix that.
Well, yes, and so there's hope and there's progress and there's specificity that's becoming available. But in the short run, if you are a woman, talk to your doctor about heart disease risk for you as a woman and then personalize it. You know, my lifestyle, my issues, my history as a female. What's my degree of risk? What's likely to happen? Is there anything we need to be doing? And the medicines that may be given for men, like statins, you need to know to have the conversation with your physician about your heart health.
It's very important, and don't let them go, oh, just forget about it, I'll think about it for you.
Yeah.
That worries me. So then you have to find somebody who will listen to you.
All right, and thank you for listening to us.
Email your questions or comments to podcast@biobalancehealth.com. You can find the BioBalance Healthcast on iTunes and on YouTube. For more information about bioidentical hormone pellet therapy and other reverse aging solutions, visit biobalancehealth.com or call 314-993-0963. You can find Dr. Maupin on Twitter @Dr. Kathy Maupin and on Facebook at facebook.com/biobalancehealth. Find Brett Newcomb at brettnewcomb.com.
BioBalance Healthcast episode 178, Thyroid and Heart Disease.
BioBalance Healthcast features conversations about positive aging. Your hosts are Dr. Kathy Maupin, Medical Director of BioBalance Health and a leading expert in treating symptoms of aging, and Brett Newcomb, a licensed professional counselor.
Welcome to the BioBalance Healthcast. This week we're going to be talking about thyroid and heart disease and the connections or combinations where monitoring your thyroid can help save you or help you repair from heart disease if you've already had it.
Well, everybody thinks that thyroid, high thyroid or elevated thyroid, is a risk factor for heart disease, when in fact it's low thyroid that is a risk factor for heart disease.
Okay.
So having said that, then I'm going to tell you about the thyroid again.
Okay, but
We've
they
done
have
this
the terms high thyroid is hyperthyroidism, and that is what everybody's afraid of. But they ought to be afraid of the sleeper, which is
Right.
hypothyroidism.
That's right.
And why should they be afraid of the sleeper?
Well, let me tell you what the thyroid does, because thyroid stimulates your metabolism. It strengthens your muscles so that your muscles work better. It causes you to, it helps you lose weight, takes away swelling, and it increases heart rate, but not too high if you have a normal level of thyroid. If you have a low thyroid, you lose your hair, you lose your outside eyebrows, you gain weight, your heart rate gets very slow, and your blood pressure can go high or very low, but not normal.
Okay.
You also get swelling in your feet and hands, and your hands are cold all the time, or you're cold all the time. So basically the thyroid is in your neck right here. It's a little gland that does a lot of things. I call it the furnace. It keeps your body temperature warm, and all of our functions in our body works better when we're warm.
It does that. It's not actually a thermostat that you turn up and down. It sends little chemical messengers to different parts of the body.
Right.
And your heart works chemically and electrically.
That's right.
And so the chemical messengers from the thyroid tell the heart to beat more, to beat harder.
To beat stronger, to actually beat at a normal rate, which is between 60 and 80. So that's a normal rate for getting blood all over your body, all through your body. It's like a pump. If you have a pool, or if you know anything about pumps, the pump has to be strong enough to get the water to the pool and then suck it back into the pump, and it's a closed system. So is your heart. Your heart's a pump, and it has to be strong enough, and it has to pump just enough, not too few pumps, not too many. So you have to be able to fill the whole pump up, and then as it closes, it pushes blood out to your whole body, just like it would into a pool. So
the objective is to maintain a steady and consistent blood flow to all parts of the body?
Absolutely. That's yeah.
So
you said it much better than I did.
It doesn't fluctuate up and down.
Right.
Because it's beating irregularly or not beating strongly enough.
Right.
So you want a consistent flow.
Consistent.
And so then if you exercise and you increase your heart rate, which is what they say to do to lose weight, how does your thyroid play into that? Does it send it signals to say, hey, speed up? Or does it then send signals to say, okay, we're done now, we're resting, slow back down?
It does speed up your metabolism. And the reason is your body needs more oxygen and more blood when you're exercising. So it speeds the heart rate, and it also increases the ejection fraction, meaning how much blood goes out of your heart with each beat. That's
rejection?
Ejection.
Ejection.
So that's a matter of how much blood is being pushed out of your heart so that you can then oxygenate all your tissue.
You were telling me before we started that everybody's afraid of an arrhythmia, and that what they need to be afraid of is low functioning heart, or hypothyroidism.
Right.
So come back and explain to me how the heart gets damaged when there's a low functioning thyroid.
Okay, well, first there's 4 kinds of damage that your heart can undergo. An arrhythmia, okay, we talked about that. An arrhythmia means a cadence, or the heart doesn't function so that you can fill up the atrium and then the ventricle and then effectively push blood out of the heart. A fast arrhythmia, or just an uncoordinated action of the heart, can actually, that's a heart abnormality that can cause damage to the heart eventually.
Okay.
And it also causes damage to the body by not giving enough oxygen to the body. So it can be an emergent situation. So that's one. The second kind of damage that we get to the heart is what we always think of with cholesterol and plaque. That's a damage from gathering fat with inflammation and coating the arteries that lead to the heart.
So like sludge inside
of it, and narrowing the volume that can go through there to feed the heart. So we're actually pumping blood out of the heart to the lungs and then back to the heart to feed the heart as well as the rest of the body. So if you have really narrowed vessels, then the heart muscle at the very end of that vessel is going to die because you can't get enough blood flow to that. And a heart attack is when you have those vessels completely occluded. So they just are blocked.
Right.
Then at the end, it's kind of like at the end of that, you kink the hose off.
Right.
At the end of the hose, there's no water coming out. So in the heart, there's no blood and oxygen coming out. So that part of the muscle dies.
Of the muscle dies.
So that's a heart attack. That can cause damage where the heart just stops beating. It also can cause long-term damage where that muscle's dead, and therefore the heart is pumping without that part of the muscle. Right. And if you have multiple clots, then lots of the parts of this nice muscle that's pumped ever since we were conceived, then that pump is bad. So the muscle has areas that won't push blood out. So then we get no ejection fraction. Our ejection fraction becomes very low. We can't get enough blood to our body or to the heart to be really healthy and effective. Then there is one of the last damages is just a poor muscle. Now you don't have to have a heart attack to get a poor muscle. You can actually have a virus that will attack the muscle, and then the whole heart will not pump well. Okay? So a poor pump is basically what we come down to in all of these, but hypothyroidism acts a lot like what the viruses do, only the viral damage is usually forever, and the damage that's done by thyroid is usually reversible most of the time. So if your thyroid's low, it affects the heart by making it not be a effective pump or a strong muscle. It makes it lax, and it slows the pulse. So the pulse is slow with a lax muscle means that nothing in your body is getting quite enough blood.
Right.
It also makes you tired. You get really
why your hands get cold?
If you get cold and you get tired and you get out of breath, oftentimes that is hypothyroidism plus an ineffective heart. So those two things are the heart and the thyroid together.
Right.
So how do you know if you have hypothyroidism, right?
Right.
So we don't always sit there and think about our heart, and it takes tests to look at our heart and just determine whether our heart is abnormally beating. Usually we find out when it's a big disaster. So you want to know if your thyroid is low to begin with. So the signs are that you lose hair on your head, the outside of your eyebrows. Well, not up here. That's male pattern baldness, and that has to do with dihydrotestosterone and not.
Don't get distracted.
I won't. That's my favorite subject, though. Okay, so low thyroid again is swelling of your hands, feet, even just swelling all over, constipation, distended belly, usually just because your bowels don't work very well.
Right.
Skin's really dry and cool, and you feel cold all the time. Pulse is slow. Blood pressure is usually low or high because low thyroid can cause either one. Low thyroid causes the vessels to be stiffer, so sometimes that causes high blood pressure. Sometimes the pump is so bad it causes low blood pressure, so it could be either one. So basically people look really puffy, swollen, and they can even have a goiter here, like a big mass here when the thyroid's not working.
An iodine issue.
It can be.
But it can also be a thyroid issue.
Right.
I did not know that.
Iodine is one of the parts of a thyroid molecule.
Okay.
You have to have iodine.
So the wheels just start falling off, and you recognize they're wobbly or they're off, and that tells you it's a thyroid problem. Check the thyroid.
Right. Check the thyroid.
Okay. Now that's observational and anecdotal. I come in and tell you I'm cold all the time, I'm short of breath, I'm tired, I have trouble going to the bathroom. Are there medical tests that you can run as well?
Yes, but usually I can tell somebody has a low thyroid across the room. That's one of my favorite games I used to play with my daughter. I'd be like, she's a doctor now. Okay, look around the room. Tell me who has a low thyroid in here. I mean, it was fun.
I play the same games with my wife. We surround each other. Okay, who's crazy?
That's probably more fun.
Yeah.
Okay, so the testing is a blood test. Just basic screening to see if you have a low thyroid is a blood test. So the blood test is thyroid stimulating hormone, TSH.
Okay.
It's a hormone from the pituitary, so you're indirectly looking at the thyroid. The pituitary puts out a stimulating hormone that then through the bloodstream goes to your thyroid, stimulates the thyroid, and then when you get enough thyroid hormone, which is called T3 and T4, it circulates back and shuts down the stimulation. That in a perfect system. If you have
So
low
there's a
thyroid,
positive feedback system.
Right.
It leaves the pituitary gland, runs to the thyroid, builds up or turns on whatever it's supposed to do. When it balances, it runs back up to the pituitary and says, okay, we've got it.
right.
Okay.
Now, malfunction is some people their thyroid doesn't function and is low because they've had a brain injury and they can't stimulate their thyroid.
Right.
So that TSH is really low and their thyroid hormones are really low.
So you know if the TSH is low, that the thyroid is probably out of balance.
Right. But it can be, the combination has to be looked at.
Right.
If TSH is low and thyroid hormone's low, that's a pituitary or a brain problem.
If they're both low.
If they're both low. But if the TSH is high and the thyroid hormone is low,
Well, now there's two thyroid hormones, T4 and T3.
usually they're both low.
Okay.
Okay, so usually both of them are low, but if the thyroid hormone TSH is high and these are low, that means that the pituitary's pushing the thyroid to
Right.
try to make hormone, and it just keeps going up and up, higher and higher, because it's not getting any back to shut it off. The feedback system's not working. So that's what we look for when we look at blood work for hypothyroidism.
Okay, I knew somebody one time that said that their doctors went in and killed their thyroid, so they
I
then
love your
had to
stories.
take thyroid medicine.
That's basically what happens. That's a treatment for hyperthyroid.
Okay.
Too
running wild.
active a thyroid. That's often an autoimmune disease where you attack your own thyroid, and as it's being attacked, it's hyperactive.
Right.
Makes too much thyroid hormone. In that case, you lose weight. You're jittery. Your pulse is high, really high, and you can't concentrate. And you just feel like you're buzzed all the time. You can't sleep. So that is, you have to have your thyroid ablated, is what that burning out thing costs,
Kill my thyroid.
or removed, or there may even be a mass in your thyroid that's causing this whole thing.
Yeah.
And sometimes they just take the mass out. So this is,
But that's hyper.
That's
we were talking about
hyper.
hypo. Sorry to distract you.
and that does affect heart function in terms of it just makes the heart beat so fast it can't fill properly to get blood out.
Right.
So we treat that with medication. But we're going to go back to hypothyroidism
Right.
because that's the one that everybody thinks has nothing to do with the heart. You know, they think, oh, we don't have to treat that. Well, if you don't treat it, then you're going to get heart disease down the line. So you have to treat your thyroid. It's very important. So where were we? So we were at the testing. T4 and T3 are low, or one of them is low.
Right.
Generally, the thyroid is low. Okay?
Right.
So we have to replace it. We don't stimulate it. We don't do anything like that. We just give the patient, you or me, thyroid medicine, and it's oral. You don't have to have it put under the skin like testosterone. It's a
what
medication.
does it replaces the T4 or the T3
Well, it depends on the thyroid
or
medication.
the TSH?
The T4 or the T3.
T4,
We don't
not the
replace the
TSH.
TSH.
Okay.
So the T4 is what Synthroid or Levoxyl or levothyroxine is. That's all just T4. And then Cytomel or liothyronine, if you're familiar with this
I
and
love
you've
when she
taken
talks
these.
like that.
So that's T3.
And what's the difference?
T-
I mean, at a cellular level,
At a cellular level, T3 is a much more active hormone, and it actually really stimulates the activity. Everything that the thyroid does, it actually gets it going faster. The downside of the just T3 therapy is that it can cause you to have too much or a hyper thyroidism. So if you take too much, it's really rapid and it can cause you to have an arrhythmia. So we, on that drug, on that medication, we slowly come up.
so it's kind of like buying high octane gas and low octane gas. The high octane's the T3, makes it work really efficiently. If you give it the low octane that's got T4, they've got an extra iodine molecule they have to get rid of for it to work.
Right, because T3 is the active form. So basically, you have to make all of your T4 into T3. Now, some of us, like me, genetically don't have that enzyme.
Right.
So every woman in my family from an early age has low thyroid because we can't make our T4 into the active form.
So you would just respond to T3 only.
Right, or a combination thereof. You have to have a little T4 for other things. I mean, it's better to be balanced, just like we were intended to be. I try to get everybody back to like the way God made us. So some T4 and enough T3 to keep everything active. So when I have somebody like that, and most women tend to lose the ability to make T3 out of T4 when they're stressed, and I don't know any women who aren't stressed. So in general, I try to give them both. I give them T4 and T3 together in one pill, which is more efficient, called Armor Thyroid, and it's pig thyroid.
Right.
That's what we use, and it's very effective. Most women do great on it, but I've used Synthroid on women, and I've used Armor Thyroid on men, so I can switch back and forth to make the fit proper.
Well, talking about men and women, I still have a question about this because throughout all our podcasts, for anybody that watches them regularly, there's always a question, like when you do a blood test to measure T4, T3, TSH, the normals for men and women are different.
The normals for men and women have been different for 20 years when they did a huge study, and they determined that women's TSH, okay, remember TSH, when it goes up, that means low thyroid. Women have a lower trigger for them to have low thyroid. So in other words, if a woman has a TSH that goes up to 2.5 or above, they have low thyroid.
Okay.
But a man, if a TSH has to go up to 4,
for doctors to say, oh, his is low.
His is low.
All right.
Now, most doctors don't accept that because they just accept the status quo from 15 to 20 years ago, which was both of them are the same and it's too much trouble to think about it, and we'd be treating too many people according to them.
Do the lab reports now show the difference, or do they just show normal is 4?
Most lab reports just have the male normal. And the male normal came from, 1940-something, when they tested male medical students. All were age 28, 29, I can't remember which, but young, healthy males. No females were in the study again, gender
bias.
So when they did check the two sexes, they found that they were different. So we're still depending on this 1940-something study that it has lived way past its prime. So we should be looking at the gender difference in this. So a lot of women are undertreated. Their doctors say, your thyroid's normal. Their hair's falling out. Everything else is...
Their hands are cold.
And their heart, they're getting heart problems, and they're not getting enough blood flow. They get out of breath when they work out. They're gaining weight. So they come to me and say, well, what do you think? And I'm like, well, let's look at your lab. Well, they fit the women's criteria, but just to go one step further, I go back 25 years when we used to just test basal body temperatures.
Right.
And a basal body temperature, first temperature in the morning before you get out of bed orally, should be above 97.9 if you have a normal thyroid. That's the very lowest it should be. Well, many women are 96.9, 97.0, and that's a sign of hypothyroidism. So those people I treat as well. Oftentimes your blood test looks good, but your thyroid...
The simple old-fashioned...
is better. It's cheaper, too.
Yeah.
You have to pay for a test. I
Right.
I could just do that.
Right.
Yet, I'd like to have some to see if the lab test really works for that person or not, if we follow it.
So you do like to get the lab test in?
I like to do both.
If somebody comes in with a low basal body temperature and you give them thyroid and then their temperature gets where you want it, then are you satisfied? Or do
If their symptoms go away.
Okay.
I have to have symptoms and the temperature, or symptoms and the lab get better.
Right.
Because
So
there's
at the
a lot
end of the day,
hanging
then the
on
goal
this.
is symptom reduction.
Right,
Yeah,
that's
yeah.
right. And it's not about just treating a number, it's about treating the symptoms.
The person, right.
And that, when all those symptoms get better, then I know that the heart's getting better.
Okay.
So they won't be out of breath when they work out, and their heart muscle is not getting lax, and it's kind of like an old pair of hose that you just keep wearing, and it just kind of doesn't form on your leg. It just kind of hangs. The muscle just gets kind of lax and it doesn't work very well.
So to summarize, there are 4 or 5 symptoms that if I present to you with these symptoms, makes an alarm go off in your head to say low thyroid. And that really needs to be attended to. People fear the arrhythmia, which is hyperthyroid, but they really need to be more aware of the low thyroid, because over time that leads to heart damage.
That's right. And people who have a heart attack, when they have low thyroid, don't recover as well. There's several recent studies about that, where if you have hypothyroidism and it's not treated, and you have a heart attack, then it's very hard for your heart muscle to heal. And so you may not get back to your old vigorous self without the thyroid.
So if you have these symptoms, and we'll run through them again just as we close, be sure that you talk to your physician about it and say, can you please check my thyroid?
And do you know about the gender difference? And my basal body temperature is blank.
Yes.
And they should know that too.
Right.
Because that's, I mean, we still know about basal temperature.
Go to the drugstore and buy a basal body thermometer.
You just need a regular one. Just put it under your tongue. It's not like with infertility. They had a special for thermometer.
Yeah,
I think that was a gag.
God, I remember those.
It was terrible look on your face.
Yeah.
But all you need is a under the tongue thermometer. That's it. And then you just write it down, because you won't remember it because you'll be tired.
Not one of those electronic ones that you put in your ear?
That's not as good. I would rather just have an oral temperature.
Okay.
And then that will help you know.
So run through the symptoms one last time.
Hair loss, eyebrow loss, dry skin, goiter, swelling, belly distension, constipation, in fact, hair loss all over your body, usually.
Cold hands
and feet.
Or cold all the time.
And you're cold all the time.
Yeah. And when she says eyebrow loss, she's talking about from the outside
out
in.
Here.
So out by the side of your ear towards your nose, it begins to go away. So you just get this little bitty piece of eyebrow left.
That's right. Yours are growing in really nicely.
Mine are coming in. So thank you for listening, and come back next time.
Email your questions or comments to podcast@biobalancehealth.com. You can find the BioBalance Healthcast on iTunes and on YouTube. For more information about bioidentical hormone pellet therapy and other reverse aging solutions, visit biobalancehealth.com or call 314-993-0963. You can find Dr. Maupin on Twitter @Dr. Kathy Maupin and on Facebook at facebook.com/biobalancehealth. Find Brett Newcomb at brettnewcomb.com.